difficult decision in our critically ill child. We need to decide whether we should continue offering life-sustaining care to our comatose patient, or we need to decide whether we withdraw this care. And usually withdrawal of this care comes about once we declare the child to be brain dead. So we are found at crossroads as clinicians, and we need to critically decide what path to follow. So today's discussion will center around who calls the shots when it comes to withdrawal of life-sustaining care in the critically ill pediatric patient, and what exactly is brain death. So we'll do this by reviewing two articles. The first is a publication by BMC in 2022 that looks at physician decision-making processes about withholding or withdrawing life-sustaining treatment in pediatric patients, and this will be a systematic review. So basically, we'll be trying to see how a clinician comes up with the decision whether to continue to put a child on the ventilator or to take this child off the ventilator, and what influences the physician's decisions. We'll also go through some guidelines in Africa on the determination of brain death, and the best guidelines I found were published in South Africa by the South African Journal of Critical Care in 2022. So before we dive into these journals, let's remind ourselves about disorders of consciousness. So usually when you're faced with a pediatric patient who comes to you, sometimes they may come in disorders of consciousness. Commonly, in pediatric patients, we usually use the AVPU scale. But when we go into further detail, these patients fall into a spectrum. So the most severe patient would usually be a patient who's brain dead, and that will be the focus of our discussion today. A patient can otherwise be defined as comatose, which is the severe end of a disorder of consciousness. A comatose patient is one who's unaware of the surroundings, unaware of self, and lacks a sleep-wake cycle. In a normal individual, we have what we call a sleep-wake cycle. So we're awake and when we're asleep. And when we're asleep, we go through either REM sleep or non-REM sleep. So usually if a patient is comatose, they lack this cycle of sleep and wake, and usually the eyes are closed. Otherwise, the patient can be in what we call an unresponsive wakeful syndrome. This was previously referred to as vegetative state. And the diagram on the right is an example of a patient who's famous, that is Michael Schumacher. This is a famous rally driver who sustained a severe head injury while out skiing with his family. He subsequently was declared to be in a vegetative state. So vegetative state or unresponsive wakeful state is a state where a patient is unaware of self, unaware of environment, but the patient has preservation of the sleep-wake cycle. So this patient goes through wakefulness and sleep, and in sleep they go through REM and non-REM sleep. And there are ways of determining whether this patient is going through the sleep-wake cycle. So Michael Schumacher is a good example of unresponsive wakeful syndrome. Otherwise, patients can be defined as being in a minimally conscious state. So a minimally conscious state is where a patient is sometimes able to respond to some commands, like for example, minimally conscious state plus, the patient can blink twice for a yes, once for a no. And patients can emerge from the minimally conscious state or be in a state of confusion. Further up, patients can emerge from the minimally conscious state with either severe or moderate disability. And sometimes we're fortunate enough to have a patient making a full recovery. We also have other disorders of consciousness, such as locked-in syndrome. In locked-in syndrome, these patients usually have a lesion in their brainstem that renders the patient to be quadriplegic. The patient, however, has intact consciousness, but is unable to move. The only movement that is preserved is the vertical movement of the eyes. So usually a family member would be the first one to detect that the patient is able to communicate by moving the eyes up and down. We also have another state of disorder of consciousness referred to as a kinetic mutism. In this condition, the patient has paucity of movement, and usually the patient will move very little and will have limited speech. So how do we classify these disorders of consciousness? There are usually certain things that we look at in the patient, such as reflexes, which we will discuss. This include the caloric test or the oculovestibular test. We have what we call the doll's eye reflex. We also have spinal reflexes, which I'll discuss. We also look at the patient's communication, the patient's executive functioning, which is usually a function of the frontal lobe, as well as language, emotion, and perception. So if a patient falls under this spectrum, the most severe point would be a patient who's brain dead, which usually comes after a comatose patient. But what exactly do we mean when we talk about brain death? In many books, it's nowadays referred to as death by neurological criteria. So for a patient to be declared dead, it can be either neurological or cardiac. And the focus of our discussion today will be on neurological criteria. So there are various institutions that have attempted to define what brain death is. And remember, we're referring to brain death in the context of a hospital setting and not what we're usually used to when the heart stops beating, when there's no respiratory effort, and when the pupils are fixed and dilated, which is what we're used to. Patients who are brain dead would usually have a normal heart rate, but there are certain things that we look at to define them as being brain dead. When we look at the African setting, the South African Journal of Critical Care 2019 attempted to define brain death, and they refer brain death as the clinical point of irreversible loss of capacity for consciousness and the irreversible loss of capacity to breathe. So this patient cannot breathe on their own, and the patient would be unconscious or comatose. The World Brain Death Program defines brain death as complete and permanent loss of brain function as defined by unresponsive coma with loss of capacity for consciousness, brainstem reflexes, which I'll go over, and inability to breathe. While the Canadians refer to brain death as permanent cessation of brain function characterized by complete absence of any form of consciousness, absence of brainstem reflexes, and ability to breathe. The Americans define brain death as permanent coma with no evidence of function of the brain as a whole and loss of all brainstem function coupled with inability to breathe. So I've highlighted in color some of the similarities worldwide that we use when we define someone as brain dead. These definitions are very important, especially in the legal context, because they can be challenged by patients. So this was a study done by Wangari, Waweru et al. In Aga Khan University, where they looked at brain death determination in sub-Saharan Africa, particularly in Kenya. And what they noted was that in Kenya, we really don't have a specific definition of brain death, and usually we use the literature worldwide. They, however, noted that there are many cultural, ethnic, and religious diversities that create a complex perspective about death, which challenges the development of uniform guidelines of brain death in Africa. So this is a study that was published by BMJ in 2022. It highlights the difficulties that clinicians often encounter when they are faced with a child who they declare as brain dead. So this was a 3-month-old baby who was admitted in a hospital in the United Kingdom, that is Guy's and St. Thomas. The patient came in comatose, was reviewed by several prominent physicians, and brainstem assessment was done. The patient was declared brain dead. However, in an unprecedented turn of events, this child began to breathe spontaneously. And this led the parents to launching legal action against the hospital and the clinicians who declared the child to be brain dead. And actually, this led to the United Kingdom reviewing the definition of what brain death is. And this is a complexity that we as clinicians may be faced with. This is another interesting case, and this is the extraordinary case of Jahi McMath. This is a paper that was published in 2021. Jahi McMath was a 13-year-old girl who was admitted in a hospital in California for routine oropharyngeal surgery. Unfortunately, during the surgery, she suffered hemorrhagic complications and subsequently was reviewed by several physicians and declared brain dead. A death certificate was actually issued. However, the mother challenged the definition of brain death because this child still had a heart rate, and this led to the mother actually moving the child from California to New Jersey. In New Jersey, they had religious exemption on on neurological determination of brain death. And when she was moved to New Jersey, they actually reversed the declaration of death. She was statutorily resurrected and was treated as a comatose patient. We've gone through what the definition of comatose. And Jahi actually lived for another 4.5 years. She underwent menarche, she underwent other aspects of puberty, and actually it is documented that she had intermittent responsiveness to commands, and this was seen by eyewitnesses as well as multiple home videos. So Jahi lived for another 4.5 years, and she died from abdominal complications, which were completely unrelated to what she initially presented with. This again is another complexity that we as clinicians may be faced with, because we may actually have a false positive diagnosis of brain death. And for Jahi, she actually had 4 EEGs done, which showed isoelectric activity that supported the definition of brain death. And she also had radionuclide blood flow tests, which showed absence of blood flow to the cerebrum, again, which supported the definition of brain death. So this raises a lot of bioethical issues for clinicians when they have a critically ill patient and they have to declare them brain dead. Another interesting case is that of Louis Viljoen. This was a young man who lived in South Africa, who was involved in a road traffic accident and subsequently declared to be in a vegetative state. He lived in the vegetative state for several years, and several years into his vegetative state, his parents and clinicians noted that he was clawing at his mattress during the night. They thought that he was suffering from insomnia. Remember, we say that patients in vegetative state have preservation of the sleep-wake cycle. The doctor prescribed zolpidem. So zolpidem is a non-benzodiazepine hypnotic that works in the GABA A receptors. And when the patient was given this medication to treat the insomnia, 20 minutes later, he actually awoke after having been in a vegetative state for many years. His first words were actually, "Hello, mommy." He began to talk and he actually began to eat and move his limbs. However, after the drug wore off, he went back to his unresponsive state. And this response was repeated severally with the administration of zolpidem. So how would you declare this patient if you were the clinician faced with this case? How would you explain a patient who's been vegetative for many years, being given a drug and being able to awaken? So the questions that we'll attempt to answer are: who decides on withdrawal of life-sustaining care in a critically ill pediatric patient? What's the role of the clinician, the parent, and the child, especially children who are critically ill, such as cancer patients who are able to make a decision on what they want? What principles guide clinicians when making decisions on withdrawal of life-sustaining care? Is it personal preference? Are there guidelines that the clinician looks at? Are there any religious influences on the clinician? And we'll also look, are there any guidelines on brain death determination in Africa, specifically in Kenya? And does our national approach and individual approach align with those of contemporaries worldwide? So the first article that I look at is the one published in BMC 2022 that looks at physician decision-making process about withholding or withdrawing life-sustaining treatment in pediatric patients. And this was a systematic review of evidence. So as an introduction, the article noted that deciding whether to withhold or withdraw life-sustaining treatment at the end of life in pediatrics is quite difficult for the physician and ethically sensitive. Little is understood how and why we physicians decide on withholding or withdrawing life-sustaining care at the end of life. What helps the physician decide whether to continue putting this patient in the ventilator, especially if it is futility in these attempts? And what makes the physician decide to declare a patient to be brain dead? Physicians are regarded as the primary caregivers of pediatric patients in the end of life and play a pivotal role in decision-making. They're responsible for advocating for the best interest of the child, providing medical information to stakeholders, and supporting parents and children throughout the care process. So it's important to understand physicians' perspectives when they are faced with a decision to withhold or withdraw life-sustaining care, and it is key to understanding this ethically sensitive end-of-life practice. So what is end-of-life care? This is the healthcare provided in the time leading up to a patient's death, and it encompasses care and support for the patient's mental and emotional needs, as well as physical comfort, spiritual needs, and practical tasks. We also have palliative care, which we commonly offer in the pediatric patients, especially those with cancer. And it is active total care of the child's body, mind, and spirit. And it also involves giving support to the family. And it usually begins when the diagnosis of the illness is made and continues all the way throughout the illness, regardless of whether the child is receiving curative treatment. It is not a discontinuation of care, but rather it is a different concept of healthcare that focuses on improving the quality of life. So the aim of this particular article was to synthesize results from different literature on physicians' perspectives about decision-making when dealing with withholding or withdrawing life-sustaining treatment in pediatric patients. So this particular article, as I mentioned, was a systematic review, and it used several electronic databases to get the information. 6 categories of such items were used, including pediatrics, target population, so it was looking at physicians' decision-making process, end-of-life care, withholding or withdrawing life-sustaining treatment, as well as perspectives of physicians, which included their perceptions, attitudes, and experiences. The inclusion criteria for this particular article was children who are 18 years and younger, publications in English, and studies that were between 2004 and 2021. The participants included practicing physicians and non-physician clinicians, children, adolescents, and parents. And the outcome measures were physicians' perspectives, perceptions, attitudes, experience, preferences, values, feelings, and opinions towards the decision-making process, and measures that focused on the different steps in withdrawing or withholding life-sustaining treatment in pediatric patients. So, exclusion criteria for this particular article was studies that included dissertation, books chapters, or conference abstracts, participants in the study, so studies in which only perspectives of non-physicians such as nurses, midwives, trainees, or students were excluded from this study, and the outcome measures of only palliative care or end-of-life treatments, complementary alternative medicine or euthanasia, or withdrawing or withholding life-sustaining treatment in neonates. So these were all excluded from this particular article. And the study population, 499 physicians participated in the studies, and this included a wide range of physicians, including pediatric intensivists, nephrologists, hematologists, general pediatricians, neonatologists, neurologists, cardiologists, general practitioners, as well as rehabilitation specialists. And out of these 499 physicians, 169 physicians, the specialty was not defined. So the sample size ranged from 2 to 69 for each of the studies, and 14 articles were included, and this only included physicians. The remainder of the studies included other healthcare professionals, parents, or additional children. The 30 included articles had 5 articles that reported on physician attitudes regarding withholding or withdrawing life-sustaining care, and the remaining articles reported on physicians' experiences. So the first question that we aimed to look at was who should be involved when it comes to decision-making processes, what are the roles of those involved, and how do they experience their involvement? So first, it looked at physicians' viewpoints. And decisions should be, and it was noted that decisions should be made jointly by physicians, parents, and patients. So physicians should not make a decision solely on withdrawal of life-sustaining care. They should involve the parent, and if a child, especially adolescent, is able to, they should be involved. And it was noted that physicians play a pivotal role in the decision-making process, and they're the ones who provide parents with appropriate information about their child's critical condition to assist the parent in making an informed decision. Physicians expressed negative feelings, including struggling with carrying the weight of responsibility for making decisions to withhold or withdraw life-sustaining care. It's a very heavy decision for a physician to decide to pull a child out of the ventilator. Physicians also feared therapeutic obstinacy when they knew a given treatment would not benefit them. So also parents should be involved in the decision making process. So many parents experienced positive, negative, or mixed feelings when they were involved in deciding whether to withdraw or withhold life-sustaining care for their children. And most parents actually, when we were interviewed, understood the inevitable need to withdraw or withhold life-sustaining treatment. And this emphasizes the importance of involving parents in this process. Parents face difficult situations when confronted with therapeutic futility. This could make parents psychologically vulnerable and hinder them from participating in decision making. So, usually, sometimes the physician needs to carefully tailor the information that they give to the parent so that the parent is able to make an informed decision. Children should also be involved in the decision-making process. And only eight publications discussed what physicians did or could do to involve pediatric patients in the decision-making process. Respect for autonomy was regarded as more important for adolescent patients, and determining when and how patients should participate in treatment decisions was described as a real challenge for many physicians. So, what's the structure of the decision making process? So, the decision making process to withdraw life sustaining care should be divided into three stages. Early preparation via advanced care planning is very important. And where I trained, this was something that was constantly done for all patients before a decision was made to withdraw them from life sustaining care, especially the critically ill patient in ICU. Information giving and receiving is important, and this is the main decision-making process where stakeholders exchange and discuss information. So you should have an MDT involving the parents, involving the palliative care team, involving various physicians, be they neurologists, critically ill specialists, or other physicians who are involved in the care of the patient, and arriving at final decision about withdrawing or withholding life-sustaining care is the third decision-making process. So for the early preparation for decision-making process via advanced care planning is to discuss values, preferences, and goals of care with parents and children through an exchange of relevant information. Remember, in our setting, there are a lot of religious and cultural beliefs that can influence the definition of brain death, and also to improve quality of care and make decisions that were in the best interest of the child. Physicians identified both facilitators and barriers in realizing these aims. The four key facilitators in early preparation stage of decision making via advanced care plan include shared decision making between the healthcare provider and parents, supportive setting. So you must ensure when you talk to the parents, you're very empathetic and you put them in an environment where they're able to express themselves. Early ongoing conversation starting at the time of diagnosis and when the patients were still well enough to discuss their condition, value, preference, and goals. So for example, if you have a patient who's diagnosed with a condition which we know has a poor prognosis, if the patient, especially adolescent, is able to express themselves, you should give this patient an opportunity to express what they would want done in case they reach a point where an end of life decision has to be made. And involvement of healthcare practitioners with special training and sufficient expertise in advanced care planning discussions should be done. So some of the barriers hindering early preparation stage of decision making via advanced care planning include uncertainty issues regarding early recognition of life-threatening conditions and difficulties that healthcare practitioners experience in reaching a consensus about appropriate care goals. As you can imagine, sometimes healthcare practitioners can have different opinions as to whether to continue placing a child on ventilatory support or to withdraw the child from ventilatory support. So usually healthcare practitioners should come together, agree, and speak in one voice to the parents to prevent providing conflicting information. So, four factors that physicians perceive to hinder healthcare practitioners and parents from reaching consensus about care goals include physicians not fully knowing the care goals of parents and patients, parents' varying perspective towards end of life decisions, parents unrealistic expectations about PICU admission. If you have a critically ill patient who's going into PICU, you should tell the parent very early what the expectation is, especially if you're going to ventilate this patient. And parents' cultural, religious, and social backgrounds are also some of the difficulties that we encounter when we are coming up with advanced care planning. So the next thing is about information delivery and receipt. Elements that contributed to quality of the decision-making process included understanding the medical situation of the child. So physicians initially discussed what parents understood about the child's illness and progression to assess whether the parent could accept the eventuality of the child's prognosis. Ask the parent, what do you understand about your child's condition before you offer any further information so that you can be able to see what the parent's beliefs are and how you can pass on this information to the parent. Provided medical update of the child's current condition and prognosis based on the clinical observation of the child. So be honest with the parent, tell them the Tell them the exact condition of the child. Don't beat around the bush. Tell them what to expect long term for this particular child. And exchanging of information is also better prepares parents for possible future decisions that they might be faced, especially when it comes to end of life decisions. It's important to provide parents with updates on possible treatment options and to lay out consequences of each treatment option for the child. So it's important to tell the parents that you can either follow route A, route B, and what are the consequences of following each of the pathways. Information delivery and receipt, again, the manner of exchanging and discussing relevant information is important. It was emphasized the importance of awareness on how to exchange and discuss relevant information. Information conveyed in a simple and concise way to parents in a way that they understand. Avoid using a lot of medical jargon. Use visual aids such as neuroimaging scans if you have. And it's important not to withhold or withdraw information about the child's condition. Rather, paint an accurate picture of the child's condition to the parents and do so repetitively and in a consistent way. So it's very important to have one particular physician who will be the go-betweener between other physicians and the parents so that they speak in one voice to the parents. So the other step is the final decision. So considered in two options. You can either decide to withhold or withdraw life-sustaining care, or you can continue life-sustaining care. So when it comes to withholding life-sustaining care, this occurs when the medical treatments are clearly futile at end of life, and majority support a final decision concerning withdrawing life-sustaining care to limit a child's suffering. So three strategies are used to help parents make a final decision. You limit the range of options that they thought were futile to avoid giving false hope. So don't give parents 10 possible options that may occur for this particular child. Give them only what is relevant to this child so that this parent doesn't have false hope. When the parent can't make a final decision because of religious reasons, then the physician has to help them make this decision. And physicians sometimes may delay making a final decision because some parents need to witness their child dying to understand that the death was inevitable. Sometimes you can't make a decision to continue offering life-sustaining care. So minority of studies supported the decision to continue life-sustaining care, especially if it's futile, even in acute situations or when they're in doubt of a child's condition. So, what were the strengths of this particular article? There were rigorous and systemic approaches that were adopted. There were clear inclusion and exclusion criteria that were well tested and comprehensive. The inclusion process and quality appraisal of 30 included articles were conducted by two authors in independent fashions, and the publications originated from studies conducted in 16 different countries, which allowed for a more global perspective when it comes to decisions on end of life care. Some of the limitations of this particular article were that the literature search was limited to publications in English, and despite strict inclusion and exclusion criteria, the study reported on reporting on self-reported perspective of physicians might be affected by social desirability bias. And most of the studies were from high-income countries, which might have introduced cultural bias to the results. And the studies conducted in low-income countries were not present in this review, particularly in Africa. So in conclusion, the synthesis of physician perspectives support a view that the decision-making process is generally divided into three stages. The first is early preparation of considering a decision through advanced care planning. The second is how you give this information and how the information is received by the parents. And the third is arriving at a final decision about whether to withhold or withdraw life-sustaining care. So this review can help healthcare practitioners and other stakeholders to better understand how and why physicians decide on withholding or withdrawing life-sustaining care at the end of life in pediatric patients. So once a physician makes a decision to withdraw life-sustaining care, then the physician must now proceed and do brain death testing. We'll now review an article published by the South African Journal of Critical Care, and it looks at the guidelines on determination of brain death. So as an introduction, currently in Africa, there are no clinical guidelines on death determination, and clinicians use available international guidelines, which vary markedly and are not always applicable to the local context. The World Federation of Societies and Intensive and Critical Care Medicine recently published a document that aimed to standardize terminologies and establish minimal testing standards across the world. Some sections of this document are necessarily broad, making application to the local context challenging, especially in the African setting, which, as I mentioned, has heavy cultural and religious aspects that may influence brain death determination. So how did this article define death? Brain death is the clinical point of irreversible loss of capacity for consciousness and irreversible loss of capacity to breathe. So this patient cannot sustain their own breathing and the patient is unconscious. Death is usually determined by either neurological or circulatory criteria, and the focus of this discussion will be on neurological criteria, and it must be made in accordance with accepted medical standards. Usually, for brain death assessment, it is not necessary to wait for the pathognomic signs of death, such as rigor mortis and decay, to be present in the healthcare setting. So a physician can declare a patient brain dead without these pathognomic signs. And a correctly performed clinical examination can determine the point of death with complete certainty. In cases where there are confounders affecting the clinical examination, testing should be deferred until such confounders are resolved or ancillary testing confirms the diagnosis of death. For example, if you have a patient with metabolic or endocrine disturbances that may give you a false positive brain death, you must defer doing the brain death assessment until these confounders are dealt with. So the aim of this particular article was to provide guidelines for healthcare providers in Africa for testing process and to answer key questions that commonly arise when medical professions are called upon to determine death, in particular brain death. And the objective was to provide clear medical standards for healthcare providers to determine brain death in order to promote safe practices and to avoid diagnostic errors, as we saw in the articles that I mentioned earlier. It also provides assurance to patients, families, and the public that the determination of brain death is undertaken with diligence, integrity, respect, and compassion in accordance with accepted medical standards and societal expectations. So we need the public to be confident that we as physicians are making an assessment of brain death in the correct method using accepted medical standards. And another objective was to create a checklist for brain death and circulatory death determination so that there's consistency regardless of whichever physician is determining brain death. So the panel recruitment, this was a Delphi process, and expert panel members were recruited through the Critical Care Society of Southern Africa as experts in the field of death determination and end-of-life care, representing a broad range of disciplines within critical care. It included pediatricians, neurosurgeons, anesthesiologists, nursing, ethics, and informed consent was given by an expert panel, and ethical research clearance was obtained from the from UCT in South Africa. So let's dive into brain death testing. So there must be an established etiology compatible with complete and irreversible loss of all brain function prior to commencement of the determination of brain death. So you cannot declare a patient brain dead without having an etiology. If a patient comes into you, you don't know what is causing the patient to be comatose, you can't declare this patient brain dead until you do investigations to try and come up with an established etiology. So before you perform brain death testing, there are certain preconditions that must be present. The patient should not be hypothermic and should have a minimal temperature of 36 degrees centigrade. The systolic blood pressure should be more than 100 millimeters of mercury, or a mean arterial pressure of more than 60 millimeters of mercury. These are values in adults, so you must adjust age appropriately for pediatric population. You must have exclusion of influence of CNS depressing drugs. For example, if the patient is on an midazolam infusion or sedative medication, you must ensure that you wean off this medication before performing brain death testing. The patient should have an intact neuromuscular function. For example, in pediatric patients, if they have neuromuscular disorders such as congenital myasthenia syndrome, congenital myopathy, or GBS, then this patient you may not be able to fully assess the neuromuscular function, and they must have an intact neuromuscular function. You must correct any severe metabolic, acid-base, or endocrine abnormalities. For example, if the patient has hyperglycemia, such as in DKA, we know that these patients can come in comatose, so you cannot perform a brain death testing in a patient who's hyperglycemic or hypoglycemic. In a patient who has severe metabolic disturbances or electrolyte disturbances, such as hyponatremia, hypernatremia, hypocalcemia, hypo or hyperkalemia, correct this before proceeding with the brain death testing, or any acid-base imbalances. Neuroimaging is recommended when available, and the ideal should be an MRI to assist with establishing an etiology and confirming brain injury. It is recommended, but it is not compulsory. And neuroimaging is not required for the diagnosis of brain death where an obvious cause is known. So factors that may influence brain death testing include circulatory, metabolic, or endocrine disturbances. Circulatory disturbances, such as some patients who have congenital heart disease disorders who are, for example, have cyanotic spells, then it may be difficult to perform the apneic tests. Patients who have metabolic endocrine disturbances, correct this. As I mentioned, electrolyte disturbances such as hyponatremia, hypokalemia, hypo or hyperphosphatemia, hypo or hypermagnesemia, hypo or hyperglycemia. Correct all this before proceeding with the brainstem assessment. So brain death testing should be done by 2 doctors. So 2 doctors are required. One should have more than 5-year qualification as a medical practitioner, and neither must be involved in transplantation team because of the ethical considerations. And the 2 doctors should perform the brain death testing together. So you should never perform a brain death testing on your own because of the legal implications that can come, and also to reduce any personal biases that may come. The testing process compromises of several things. Number 1, you want to check if the patient is comatose. Number 2, you need to assess and see if the patient has absence of brainstem reflexes, and this includes examination of specific cranial nerves. These include the pupillary light reflex, which includes cranial nerve 2 and 3, that is your optic and oculomotor nerve, the corneal reflex, which includes cranial nerve 5 and 7, which is your trigeminal and your facial nerve, responds to pain in the trigeminal distribution, which would be again your trigeminal and your facial nerve. The vestibular ocular reflex, or what we call the caloric test, which would include cranial nerve 3, 4, 6, and 8. We can also do the doll's eye reflex, which is the oculocephalic reflex. We can also do our gag reflex and our cough reflex. So once you check absence of brainstem reflexes, then you proceed and do your apnea test, which is the inability to breathe. So you should only proceed with the apnea test if all the above reflexes are absent. So let's go over each of these. So we said for brain death testing, the first thing that you should do is check if your patient is comatose. And how do you do this? You apply deep pressure to the temporomandibular joint, the supraorbital notch bilaterally, the sternal notch, and all four extremities via deep nail bed pressure. There should be no true motor response. Now, the reason they say no true motor response is sometimes you can have a spinal reflex. So a spinal reflex can occur in a patient who's brain dead. For example, if you apply deep pressure to the nail bed, we can have what we call the triple flexion response, where the patient flexes at the hip, at the knee, and at the ankle. So this is not a reflection of brain activity, but it is a spinal reflex. So the reflex goes through your sensory nerve, through the spinal cord, and then back through your motor nerve, and the patient will withdraw, but the patient is brain dead. You can also have what we call the Lazarus sign. So Lazarus sign is another spinal reflex. And a patient who's brain dead, sometimes you may find the patient actually is able to elevate the hands and lower the hands across the chest. So this is not a true motor response. And if you see the patient doing this, don't think that the patient is not brain dead. Next, you do your reflexes. So we've talked about our brainstem reflexes. The first is the pupillary light reflex. So you shine a bright light into the eye and look for pupillary constrictor response. As I said, it involves cranial nerve 2, which is the optic, and cranial nerve 3, which is the oculomotor response, as you can see in the top diagram. There should be no pupillary response. Next, you check your corneal reflex. So for the corneal reflex, it involves cranial nerve 5, that is the trigeminal, and cranial nerve 7, which is the facial. So the facial nerve innervates the orbicularis oculi. So usually what happens, if you touch the cornea with soft cotton wool or gauze and examine you usually will examine the eyes for blink or a withdrawal response. There should be no blink, there should be no withdrawal. There should be no withdrawal response. And this would be an indication of brain death. Next, you check response to pain in the trigeminal nerve distribution. So you apply pain over the trigeminal distribution, and this includes pressure over the supraorbital nerve and to the condyles at the level of the temporal mandibular joint. There should be no facial or limb movement. Next, you check your gag reflex. So the gag reflex will be your cranial nerve 9 and 10. That is glossopharyngeal and vagus. How do you do this? You stimulate the posterior wall of the pharynx on both sides with a tongue depressor or a young casaca. There should be no gag response. Sometimes if the patient is ventilated, you can tug on the ET tube and see if the patient gags. So there should be no gag response. Then you check your cough reflex. And the cough reflex we said is cranial nerve 10. So you stimulate the tracheobronchial wall, often done with a soft suction catheter. There should be no cough response. And remember, absence of these responses means that the patient is brain dead. Next, you do your vestibular ocular reflex. So vestibular ocular reflex is what we commonly call the caloric test. Before you perform the caloric test, you must do otoscopy, look into the external auditory canal, confirm that the eardrums are visible, so there should be no wax, there should be no foreign body. If the eardrum is not visible, then the canal must be cleared before testing. Ensure that the patient doesn't have any history of trauma to the cervical cord. You then proceed and elevate the head to 30 degrees. And the reason you do this is to align the semicircular canal and generate a maximal response. You then take 50 ml of ice cold water and splash it into the ear canal using a syringe. And you hold the eyelids open and observe for eye movement for a minimum of 60 seconds. There should be no movement, eye movement in the eye in response to cold water, and the eyes remain in the midline within the socket. This is an indication of brain death. Brain death. In a normal individual, when you put cold water into the ears, usually you look for a caloric response. So usually there'll be a brief period of nystagmus. So usually we have what you call a fast response and a slow response. So when you use cold water, usually you're looking for the fast response. So when you put cold water into the eardrums, the eyes will quickly move in the opposite direction and then slowly return to the same direction. However, if you use warm water, the eyes will move. The fast response will usually be in the same direction as the ear that you're testing. So that's you'll commonly hear the acronym COWS used. So cold, opposite, warm, same side. So that's just telling you in a normal individual, when you perform the caloric test and you splash ear into the left ear, the cold water, the fast response moves to the opposite side. If you use warm water, the fast response moves into the same side. And that's just a brief episode of nystagmus. So when doing brain death testing, you must do these investigations that I've mentioned before you perform the apnea test. And I will discuss the apnea test in the next slide. Observations that are incompatible with the diagnosis of brain death include if you witness any seizures, if the patient has decorticate or decerebrate posturing, or if the patient has a true extensor or flexor motor response. Remember, we mentioned that we can have a false spinal reflex. Observations that are compatible with the diagnosis of brain death include the spinal reflex that I mentioned, that is the triple reflex response or the Lazarus sign, if the patient has sweating, blushing, tachycardia, or a normal blood pressure. So once you perform these tests, you now move on and perform apnea testing. So only proceed with the apnea test to confirm brain death if all other brainstem reflexes that I've mentioned are absent and if the patient is hemodynamically stable. The patients may be on inotropes. Two doctors should perform a single apnea test together, never alone because of the legal implications. So what is the testing procedure? You need to pre-oxygenate the patient with 100% oxygen for 10 minutes to prevent hypoxemia during the test. Perform a baseline ABG, that's an arterial blood gas. So the baseline PCO2 should be the normal 35 to 45 millimeters of mercury. And your pH should usually be normal, that is more than 7.35 to 7.45. If the patient is ventilated, which would usually be the case, disconnect the patient from the mechanical ventilator and supply continuous oxygen either via a T-piece or through a catheter inserted through the endotracheal tube and placed just above the carina. Observe continuously for any spontaneous breathing. If there's any spontaneous breathing, then the patient has failed the apnea test and the patient is not brain dead. There are certain conditions, certain circumstances where you may need to halt testing. So halt testing if spontaneous respiration is witnessed because the patient is obviously not brain dead, if the systolic BP falls to less than 100 millimeters of mercury, or if your MAP falls to less than 60 millimeters of mercury, despite titration with inotropes, if you're performing the apnea test and the SpO2s fall to less than 85%, you must stop your apnea test, or if the patient has an unstable arrhythmia, such as ventricular tachycardia or ventricular fibrillations. It is suggested that prior to abandoning the apnea test due to cardiorespiratory instability, perform an arterial blood gas, and if the PCO2 target is met that I will discuss, the apnea test can be considered to be positive, and this would be consistent with brain death. So how do you interpret an apnea test? In cases of brain death, apnea must be demonstrated in the presence of an adequate stimulus to spontaneous ventilation. That is, if your arterial PCO2 is more than 60 millimeters of mercury and your arterial pH is less than 7.3, then you can consider the patient to be brain dead. Some patients may have pre-existing hypercapnia, meaning that their PCO2s would be high, usually above 45 millimeters of mercury, and it is recommended to wait for the PCO2 to rise more than 20 millimeters of mercury above the chronic level and a pH of less than 7.3, and these values can be used to declare a patient to be brain dead. Attempt at breathing is defined as any respiratory muscle activity that results in abdominal or chest excursion or activity of accessory respiratory muscles. Remember, if a patient attempts to breathe, then the patient has failed the apnea test and the patient is not brain dead. So how long do you perform the apnea test? The period of observation to achieve an adequate threshold of stimulus of respiratory center is variable. Usually, the PCO2 rises by about 3 millimeters of mercury for every minute of apnea. So if you're starting at normocarbia, if the PCO2 if the PCO2 is likely to be more than 60 millimeters of mercury after 10 minutes, considering that you have a rise of 3 millimeters of mercury for every minute. If this is not the case at 10 minutes and the patient is stable, you can prolong the apnea test for a further 5 minutes and repeat your arterial blood gas, looking to see if the PCO2 is more than 60 millimeters of mercury or more than 20% rise from the baseline. If you're unable to complete the test, so if unable to complete testing, you need to consider if the patient is hypoxic, then you can give 1 to 2 positive pressure breaths and continue the apnea test, or ensure that you have adequately pre-oxygenated the patient, and recruitment usually will avoid the problem of having to abandon performing the apnea test. So just to recap, apnea test should be performed for at least 10 minutes. Do an arterial blood gas prior to the apnea testing. Usually the baseline PCO2 should be 35 to 45 millimeters of mercury, and the pH should be above 7.3 millimeters of mercury. After 10 minutes, do an arterial blood gas. If your PCO2 is more than 60 millimeters of mercury and your pH is less than 7.3, the patient has failed the apnea. The patient, then you can consider that the patient is apneic, or if you have more than 20 millimeters rise in your PCO2, then again, the patient has failed to have any spontaneous breathing. So what about ancillary testing? So sometimes you're not quite sure. You've done your apnea test, you've done your brainstem reflexes, and you're not really sure whether to declare this patient brain dead. So there is a role for ancillary testing, but it is recommended that the clinical exam be completed to the fullest extent possible prior to conducting any ancillary testing. And some of the ancillary testing that I'm talking about include doing EEGs or radionuclide studies to check if there's any blood flow to the brain. Ancillary testing is required in the following circumstances. If you have inability to complete a clinical neurological determination of death, including apnea testing, if you have confounding conditions which would invalidate clinical testing and that cannot be resolved, if you have uncertainty regarding interpretation of spinal mediated motor reflexes, or if you have any pre-existing severe neuromuscular disorders such as congenital myopathy, congenital myasthenia syndrome, amyotrophic lateral sclerosis, or a pre-existing severe sensory neuropathy, such as a severe form of Charcot-Marie tooth disease, then you may need to perform ancillary testing. So ancillary testing, which establishes the absence of intracranial blood flow, is the preferred method for testing where available. These include radionuclide studies, such as the diagram I've shown on the right. So you can see above is a normal patient, below is a patient who has absence of cerebral blood flow when radionuclide studies were done. Conventional four-vessel cerebral angiography can also be done to see if you have cerebral blood flow, as well as transcranial Doppler studies. Again, I'll emphasize that ancillary testing should only be performed once a thorough clinical exam has been done. EEGs should not be utilized routinely as an ancillary test, given its low specificity and sensitivity. However, if you perform an EEG, you will see isoelectric activity on the EEG, which can support a diagnosis of brain death. CT angiography and MRI angiography, which may be used in investigations of these patients, should not be used in isolation to support a diagnosis of cerebral circulatory arrest at present, pending further research into sensitivity and specificity of these modalities. So, what are the pediatric considerations in brain death? A cautious approach with a low threshold for serial examination is recommended. Brain death cannot be diagnosed in neonates who are less than 36 weeks, and clinical assessment of brain death in neonates and pediatric population is the same as in adults with age-appropriate hemodynamic targets. Ancillary testing should not routinely be used. And in cases of chronic hypoxemia owing to cyanotic heart diseases, apnea testing should not be performed, and instead, an ancillary study should be conducted to assist with determination of brain death. What about the family? What's the role of the family when it comes to an assessment of brain death? It is reasonable to provide accommodation for a finite period of time, assuming that the specific time period is brief, that resources allow, meaning for example, there's no other child who needs the ventilator, and that a family is informed of the time frame in advance, so not more than 24 hours. It is ethically and legally appropriate for the treating team to end somatic support for a body when the family has been adequately cancelled on the diagnosis of brain death and an option of organ donation explored. An additional clinician in hospital can provide the family with a second opinion, and the support should be discontinued if a person has been declared brain dead and the hospital bed is required for a living patient with no other beds available. So, training and documentation is very important for brain death assessment. All doctors working in a hospital should be trained in the determination of brain death. A standardized checklist should be used, and consultation with a medical practitioner experienced in diagnosis of brain death is advised in situations where the diagnosis and testing is uncertain. Where I trained, usually we do at least 2 brain death assessments before we make that declaration. And all phases of brain death determination should be documented. This include the etiology, absence of confounders, any neuroimaging results available, the time and date of death, as well as the identity of the practitioners who performed the evaluation with their medical board numbers. So some of the strengths and limitations of this publication was that the strengths was documentation. The document offered clear, pragmatic evidence-based medical guidelines in the determination of death. Some of the limitations was that there was lack of high quality data from large RCTs, and the recommendations were developed without direct patient, cultural, and religious input. However, the panel of experts did represent a broad range of cultural and religious viewpoints. So some concluding remarks. Accepting brain death in our society, as you can imagine, is quite difficult. The concept of brain death is difficult to comprehend. How do you tell a parent that the child is brain dead when the parent can see a heartbeat? And it's difficult for individuals to grasp this concept, especially in the African setting, on the basis of personal, ethnic, and religious beliefs. And this concept permeates throughout our own African society, where media often portrays death as occurring after the heart stops beating. And it's even common among us physicians to diagnose brain death and then write in our charts hours or days later that the child died when the heartbeat or respiratory effort ceased. And it's not uncommon for family members to debate with physicians that their child cannot be dead if the heart is still beating. Does age of the patient matter? Yes, it does. So ideally, we should not do a brain stem assessment in a child who's less than 37 weeks gestation. In utero, remember babies do not breathe, and the breathing process is dampened by prostaglandins. However, once a child is born, they're no longer exposed to maternal prostaglandins, and the apnea threshold of 35 millimeters of mercury increases from about 32 weeks gestation until 37 weeks gestation when it is normal. So neonates on prostaglandins will have an unreliable apnea test, and precautionary measures should therefore be taken. So just to conclude, I'll conclude with this particular study that was published in the Journal of Pediatric Intensive Care. So this was just to show you the importance of involving the family when it comes to determination of brain death. So this was a child who was admitted after a near drowning event in ICU on day 1 of life. On day 2 of life, the child was noted to have cessation of spontaneous respiration. On day 4 of life, the first brain death assessment was made. The initial PCO2 was 44 millimeters of mercury. Spontaneous respiration was noted at 6 minutes, so the child failed the apnea test, and the PCO2 was 77 millimeters of mercury. So this was not consistent with brain death. However, on day 5 of life, the second brain death exam was done. The initial PCO2 was 35. The child had 19 minutes of apnea, and the PCO2 was well above 60 at 108. This was consistent with brain death. On day 6 of life, the child had spontaneous respiration upon removal of the ventilator, which was not consistent with brain death. So we can see the child had 3 brain death assessments, all of which were inconsistent. However, the good thing is that the clinicians involved the family, and during a family conference, the parents elected to redirect care to comfort measures only with a plan to withdraw life-sustaining care therapies several days later. And notably, no respiratory effort was observed following removal of the endotracheal tube, and the patient maintained a heart rate or on the monitor for about 30 minutes and then entered a systole and was declared brain dead. So always involve the patients when coming up with when performing a brain death assessment. And are ancillary tests reliable in pediatric patients? As I mentioned, ancillary tests are not always reliable in the pediatric patients, and you must rely on your clinical acumen when making an assessment of brain death. So in conclusions, physicians should be in close communication with the child's family during the process of deciding to withhold life-sustaining care and determine brain death. Most physicians agree on the importance of making decisions about withholding or withdrawing life-sustaining care with parents. So it should be a multidisciplinary team approach. There are few publications considering involving the child in the decision-making process, and the few publications usually advocate for the adolescent child who has a chronic illness and is able to express their desire. Physicians should seek to achieve maximal assurance in the diagnosis and confirmation of brain death so that our patients can trust our decision. And the definition of brain death should be frequently revisited on a national basis. Thank you. I am now open for questions. Daisy,
Thank
I'll
you.
hand back to you.
Thank you so much, Lucia. That was such an interesting, very elaborate presentation. Quite eye-opening. We have a few questions. I think the first and second I'll combine so we can just keep time. So the first one is, how does one discuss goals of care with a critically ill child who's on life-sustaining care? And the second one is, how viable and reliable is the decision of a patient with impaired judgment related to the disease?
Okay, so as I mentioned, of course, if a child is on the ventilator, you can't really have a discussion with the child. You'd have to have a discussion with the caregivers and the parents. However, if at the time you make a diagnosis in a particular patient, for example, in KNH, we have a lot of oncology patients who may have cancers, that maybe stage 4 cancer in an adolescent, and the adolescent at this stage may be able to express themselves and say what they desire. So when you perform your MDT, you should listen to the patient, their thoughts, their desires. If they come to the point where they will be on the ventilator and a decision on end of life care has to be made. So this is the only point where we can involve a child when it comes to the decision-making process. Otherwise, if the child is already on the ventilator, then usually this role falls upon the parent. And again, remember, if you have a very young child, such as a 6, 7-year-old, it's really not possible to involve this child, even if the diagnosis is made early, on end of life decisions. And therefore, a multidisciplinary team approach should be used, including both the physician, the parents, as well as the palliative care team.
Thank you for that. The next one is from Dr. Muchela, and I think it's something we've come across a lot, both in private and in public sector. So in our setup, such discussions almost always trigger alternative medicine, in brackets herbal, requests that would endanger the life of the child unnecessarily. How does one reach a safe consensus with the parents in such cases?
Okay. So actually, where I trained, which is in South Africa, there's a lot of cultural beliefs on herbal medicine. They call them sangomas, and you'll find most patients and parents, before they come to a healthcare provider, they will definitely have visited alternative medication, the traditional healers. So what the university has done, it's actually engaged these traditional healers, and they frequently call them to the university to have sessions where they have sit downs, and they try and just engage them so that they can reach a common ground. So that if the patients happen to first go to the traditional healers, then the traditional healers can redirect these patients to the hospital setting if they feel that they are unable to manage it. And also, by engaging these traditional healers, they actually have been able to influence some of the practices of the traditional healers. For example, you find there was actually some traditional healers in South Africa. What they do, like for example, if they have a patient who has epilepsy, you'll find that they'll give herbal medication, but they'll mix some anti-seizure medication such as phenobarbital with this herbal medication, and the patient will end up having a response and thinking that it's the herbal medication that is working. So the best approach would be just to try that we as physicians should try and engage these traditional healers so that we can kind of have a common voice, especially in societies where there's a very strong cultural influence. And if you try and work in isolation, then you'll find that most patients would present too late. So just opening lines of communication would be the best approach for these particular patients.
Okay, so I think the next question is almost similar to that. What were your findings concerning the approach when the parent's religious or cultural leaning contradicts with medical practice, and there's a paucity of time to discuss the needed interventions with all stakeholders? For instance, a child with severe anemia, HB less than 3, and impending heart failure.
Okay. So the best approach would usually to have a multidisciplinary team approach where every clinician, as I mentioned, the palliative care team, the hospital administration, and even the legal representative of the child as well as the family should all sit together and so listen to the parents, give them a chance to say why they may be against a particular approach, but also the physicians should be able to provide insight to these particular parents. But if you find yourself in a situation where the parents are completely against offering, for example, life-sustaining care, then this is where we have to bring in the legal experts of the hospital to sit down and come up with a final decision. And a lot of times we've actually had cases where the case goes to court, and the court has to make a decision. And once the court makes a decision, then they come back and tell the parents and the physicians that this is the final decision that has been made. And this process can be extradited, because we know we as clinicians can't really make that decision on our own because of the legal implications. So there is a role for a legal pathway to follow when you find that the parents are completely contradicting the physician's approach.
Okay, I think I'll combine because there's so many questions. So I'll combine the next two For the brain death testing, is there a minimum or maximum number of tests to conclude brain death, or is it any of the above? The second question is, can this brain death determination criteria also be applied to newborns born with severe birth asphyxia and resuscitated for more than 15 minutes, but failing to pick up?
Okay, so for brain death testing, where I trained, usually we do two assessments at least 24 hours apart. And as I mentioned, you must ensure that there are no confounding factors such as acid-base imbalances, drugs that may influence your results. If you happen to have contradictory results, like for example, the first one is positive, the second one is negative, then you must repeat the test until you have consistency, or you can call a physician who's more trained in brain death assessment, or this is where ancillary tests can come in, such as the radionuclide studies, the EEG studying to help support the diagnosis. So usually two tests at least 24 hours apart by trained physicians. And the second was can this brain death determination criteria also be applied to newborns with severe birth asphyxia and resuscitated for more than 15 minutes, but failing to pick up? So remember remember I talked about the disorders of consciousness. So disorders of consciousness fall on a spectrum, with comatose being the most severe. So comatose, vegetative, minimally conscious state, and then recovery from the minimally conscious state. And when you're comatose, then that's when you usually make the decision as to whether the child is brain dead or not. So sometimes in a child with severe birth asphyxia, then you really need to assess the child and see whether they fit the criteria for making an assessment for brain death. Because sometimes these patients may just be comatose, and sometimes if you offer the appropriate therapeutic responses, such as therapeutic hypothermia, then these patients can actually do well. But as I mentioned, in children less than 36 weeks gestation, that's in units, you have to be cautious when doing brain death assessment, and we don't routinely do the brain death assessment in those who are less than 36 weeks gestation.
Okay. I think you've answered a few. It's like a comment stroke question. Very timely session and conversation for us, especially in Kenya with our strong religious beliefs. Do we have a legal framework in Kenya?
So as I mentioned, the study done by Wangari Sika et al. In Aga Khan, where she looked to see if there's any legal framework in Kenya. And what we found that most of the brain death assessment that we do is based on international guidelines. So what I found was that South Africa is the one that has the most clear guidelines when it comes to assessment of brain death. And they did adopt that from international guidelines and try and tailor it to the local context. In Kenya, no, we do not have any brain death assessment framework, and we do not have any legal framework. So most of it is usually based on physician experience, and also just there are some laws, of course, that govern this, but really we don't have any clear guidelines, and maybe this is something that we need to look into.
Okay, there's a very interesting one. Is withdrawing of life support care similar to merciful killing? And is euthanasia then allowed once you assert a patient has brain death?
Mhm. Okay, so that's an interesting question. So usually withdrawal of life-sustaining care is only done when you declare a patient to be brain dead, meaning they have absence of the brainstem reflexes, the patient is comatose, and the patient is apnea. So when you withdraw life-sustaining care, you don't anticipate this patient to continue. Basically, the patient is at end of life, and the patient would usually pass on shortly afterwards. So very rarely would you withdraw life-sustaining care after you've done an appropriate brainstem assessment and the patient continues to live for long. So it's not a merciful killing or euthanasia. So euthanasia usually is used in the context where a patient has a chronic illness and chooses to end their life. And usually when they choose to end their life, there are medications that are given to induce cardiorespiratory arrest. But in withdrawal of life-sustaining care, you have done your brain death assessment, you have determined the patient to be brain dead, and now you basically take the patient off the ventilator, and you do not anticipate that this patient will continue to live for much longer.
Okay. I think we've exhausted because most of them are just repetitions. Thank you so much, Dr. Lucia, for a fantastic presentation. And I don't know if you have any parting shots.
No, I think if you have any further questions, you can contact me, but the presentation will be shared on the KNH website. Next week, we will be looking at endocrine complications in neurological patients. So please tune in as we continue with our neurological series. Thank you.
And I'd like to thank everyone once again for joining us this evening. And we hope you've actually learned a lot. I have learned a lot, and we hope you join us next week. Thank you, and have a good evening.
Thank you. Good night.
Good night.